All right, you're live now. Go ahead.
Okay. Hello, and thank you for joining us. Welcome to the 2021 American Diabetes Association Ask the Experts. Today's topic is preventing and treating common eye complications. This is our first Zoom ATE, and we would appreciate any feedback you have for us. You will receive an email with a brief survey at the end of this program. Thank you very much for participating. My name is Carla Cox, and I'm a registered dietitian nutritionist and a certified diabetes care and education specialist, and your host for today's program. Remember that our Ask the Expert series is all about answering your questions. So get those questions ready. And remember, today our topic is preventing and treating common eye complications. So try and ask those questions kind of around that line for us. Please use the Q&A box at the bottom of your screen to ask your questions of our expert. Type your question into the Q&A box, click send. Click the thumbs up if you like that question, and then we'll know whether that's the question we should be asking because we may have more than we can actually get to. If you're on the phone, you will need to join online as there is no audio available for asking questions at this time. If you're having any technical difficulties, please use the chat function on your screen. Okay, now a little bit about why we're here today. The American Diabetes Association, together with visionary partners VSP Vision Care and Regeneron Pharmaceuticals Incorporated, is focusing on an often overlooked but costly and devastating complication of diabetes, vision loss. This eye health initiative, Focus on Diabetes, provides tools and resources for people with diabetes to learn how to reduce their risk of developing eye diseases by managing glucose values and getting a comprehensive annual eye exam, dilated eye exam, even if symptoms are not present. As part of the initiative, the ADA is holding this free educational Q&A. We'll cover information and tips to help you take charge of your health. The health and safety of all those we serve at the American Diabetes Association is always our priority, and the CDC has determined that COVID-19 is a serious public health threat. For people with diabetes, if they get COVID, they are more likely to have complications or challenges trying to manage their blood glucose. And if their glucose has been high, they have a greater risk of complications from COVID as well as from other viruses. Current CDC recommendations to protect yourself state that you wash your hands often, you wear a mask, unless I guess now you're outdoors, that you keep a social distance of about 6 feet, avoid touching your face, and cover your mouth and nose with a mask or cloth face covering when around others. The ADA encourages people with diabetes to follow the guidance of the CDC and to contact your medical provider if you suspect that you are showing symptoms or have been exposed to COVID-19. For our most up-to-date information, please visit our website at diabetes.org/coronavirus or call 1-800-DIABETES or 1-800-342-2383. Before we start opening up our Q&A with our expert, we would like to ask you a few questions. Please click on the box that best answers the question and you will see the total results on your screen. Number 1, how often do you wear sunglasses? First, every day I rock sunglasses. 2, whenever the sun is shining. Or third, I'm more of a hat person. So click on the circles. The second question, how frequently should a person with diabetes get a dilated eye exam? Every 6 months? Every 1 to 2 years? Every 5 years? Only when vision is affected, and I don't know. Question number 3, true or false? Diabetes-related eye diseases can have no visual signs or symptoms. True? false, or I don't know. And the last one is, to what extent do you feel confident that you can reduce your risk for diabetes-related eye disease? Not confident, somewhat confident, or very confident. And we're hoping by the end of this session, you'll be able to check very confident. And now I'm happy to introduce our guest for today's event, Dr. Cooper. Dr. Cooper is a talented and experienced expert in eye health, and he's been a great friend of the Focus on Diabetes initiative. Dr. Cooper completed his residency and fellowship training in ophthalmology and vitreoretinal surgery at Washington University in St. Louis. Over the past 17 years, Dr. Cooper has worked in Kansas City caring for complications related to diabetes-related retinopathy. He has a personal and professional interest in improving the lives of individuals living with diabetes. Dr. Cooper, why don't you tell us a little bit more about yourself?
Yeah, thank you, Carl. I really appreciate being here. So as you mentioned, I'm an ophthalmologist, which means I basically specialize in most diseases that involve the eye, although I'm actually a retina specialist, so that really involves the back of the eye. If you think of the eye like a camera, the retina is the film inside the camera and has blood vessels in it that can get affected that we'll talk about tonight. But my passion really is trying to help people live better with diabetes. And really that stemmed from the fact that almost 10 years ago, my oldest daughter was diagnosed with type 1 diabetes. And so that really sort of brought my work life and family life together and really trying to help people just live better with their diabetes. And I think it gave me a better perspective on what patients go through and you know, fears and concerns they have over how blood sugars can affect their body and what happens with their eyesight, obviously, is one of those things that we can talk about tonight. But you know, I'm just here to just try to hopefully shed a little bit of light, so to speak, on what I do and try to hopefully ease some concerns some of you may have about, you know, what diabetes can do to your vision.
Great, thank you so much. As we're waiting for our questions to begin rolling in, I'm going to go ahead and kick off with the first question.
Okay.
How frequently should a person with diabetes get a dilated eye exam, and why do we recommend that?
I think that's a great question. And, you know, I was a little disappointed a few years ago when the ADA came back with some changes to the recommendations. So that if you caught the question, it was every 1 to 2 years we should get a dilated exam. And those sort of recommendations changed from every year. It used to be every year, but it changed every 1 to 2 years based on your level of retinopathy. And what I mean by that is if you go in and you have your eyes looked at and there's no signs that diabetes has affected your eyes, then it's reasonable to have an exam in 2 years rather than every year. Makes me a little uncomfortable just from a standpoint that it's hard to remember what to do 2 years from now, and yearly seems to just sort of fit better with normal schedules. But the recommendation, at least from the ADA, is that you should have your eyes dilated and examined for retinopathy if you have diabetes every 1 to 2 years. Now that can actually change based on the level of retinopathy. So if your doctor realizes that there's been some changes related to the blood vessels within the retina and it's affecting your eyes, you might have to be seen more frequently. Oftentimes there's treatment that may require you to come in monthly if necessary. But typically, usually the level of retinopathy will dictate how frequently you need to be seen. And the reason that's so vitally important is that diabetic retinopathy is an asymptomatic condition that really can be halted and reversed at different stages if necessary with medications and really prevent the severe form of visual loss that comes from proliferative disease. And that's where blood vessels grow and they can cause scar tissue, they can bleed, they can detach the retina, all of which can be halted if detected early. And what I mean by asymptomatic, you can have retinopathy affect your eyes and not know it. You can have good vision, 20/20 vision, pass a driver's test, not have any problems. And you know, the blood vessels that change over time take years to sort of develop into a problem. And if you catch it early, you can halt and stop that problem.
Great, thank you. So it sort of sounds to me as though your recommendation is, for safety's sake, that every year getting a dilated eye exam is probably a good idea.
Well, I do. I think that it's important from an eye health standpoint for the retina, but it's also important to manage other conditions. So when we talk about a dilated exam, what we're talking about is eye drops that are placed into your eyes that will make the iris, which is the pupil, larger. And it does that for a few hours. And it's much easier to see the structures in the back of the eye when that happens. There are cameras nowadays that can take what we call a non-mydriatic photograph, a picture of the back of the eye. And that photograph is good. It can be used as a screening tool, and it can be good to stage and follow level of disease. But what it doesn't do for us is it doesn't allow us to evaluate other structures of the eye. So the cornea, the lens, the optic nerve, check pressure in the eye for other conditions like glaucoma. And so a comprehensive eye exam is really important. The dilated portion of it, the examination of the back of the eye or the retina, is important, but it's not the complete picture of overall eye health. In addition to obviously checking for the most common condition that affects all of us, which is some form of uncorrected refractive error, meaning needing glasses of some sort. Most of us, if we live long enough, are going to need some reading glasses. Some of us need to wear contacts or glasses to see better in the distance or up close. But really, once a year, be seen by an optometrist or an ophthalmologist is great, right? And one of the questions that came in is whether or not we should be seen by an ophthalmologist or an optometrist. And really, a good comprehensive eye exam can be done by both.
Okay, thank you so much. That was really made the different kinds of eye exams very, very clear, which is great.
Mm-hmm.
So we have a question online. I already have some damage in my vision. I'm concerned I am unable to reverse this damage.
Yeah, and that may be true. It is one of the concerns that we have, is that, you know, when we have damage, sometimes you can't undo it. And that's just a sort of sad reality. When we talk about levels of retinopathy within sort of the retina community, we assign levels, and the levels don't make any sense, but we think of it more like mild, moderate, and severe. And when you get to a certain level of retinopathy, with appropriate treatment and medications, we're able to actually reverse the stages of retinopathy. We're able to see some regression. And so if you were at a severe level of retinopathy, we're able to take you back with appropriate treatment to the moderate or even mild stages, but we're not able to undo all of the damage that could be done. Now, when we talk about damage to the retina per se, it's really damage to retinal vessels and circulation. No different than closing off blood flow to the heart and having a heart attack, or the brain a stroke. If you shut down blood flow to the retina and the retina becomes ischemic, sometimes we can't undo those damages. What also happens to blood vessels, though, is that they start to break down. They start to leak fluid and cause swelling in the retina that we call macular edema. And that swelling can be halted and stopped and improved on with medication. And oftentimes, in response to the blood vessels shutting down or leaking fluid, new vessels will grow. And that's the part that really causes lots of damage. And so we think about vision, things being a little blurry or not quite as clear as they used to be is frustrating. But unfortunately, diabetes-related retinopathy or diabetic retinopathy can cause blindness from hemorrhage, from scar tissue, and oftentimes that requires surgery. And at the early stages, we're able to stop and improve that. Sometimes, no matter how hard we try, vessels grow and they cause secondary glaucoma, or they can cause enough scarring in the retina that we can't undo that. So to answer the question, yes, some damage can't be reversed. However, there are great medications now that can really halt and stop further damage and hopefully help undo some of the changes that have occurred. But the reality is, a lot of that change occurs without us even noticing it. It's not until we maybe wake up one morning and have a lot of new floaters, or have, you know, more sort of distortion in what we're looking at, that we might pick up on a change. And you know, if people walk away with sort of one sort of main thought, realize that when we go to sleep at night, we close our eyes, and in the morning we wake them up. But we never really sort of cover one eye or cover the other one. And it's really important when we test our vision at home to do it one eye at a time, and make sure that you're not seeing any distortion. Make sure you're not having any new floaters. One of the other questions in the chat box is, what are some early signs that diabetes is affecting the vision? And it could be obviously some new floaters. It could be some distortion. But really, when we have diabetes, oftentimes our vision is going to fluctuate based on the level of our blood sugars. The lens that's inside our eye helps focus light. And that lens can absorb glucose. And if the glucose levels are high and they fall rapidly, that is going to shift glucose out of the lens and carry fluid with it, and the lens can shrink or it can swell, and that'll affect your vision. So one of the things that as an eye care professional, we'll actually be able to sometimes diagnose somebody with diabetes even before they even know it, because they're coming in and their vision just isn't ever right. It keeps fluctuating. And so that's also an early sign that diabetes can be affecting the vision.
So here's a great question too. Are floaters and blurry vision normal? I have a cataract forming, but the floater issue.
Yeah, yes, and the floaters are a normal thing. And so, the middle part of our eye is a big empty cavity, and that cavity is called the vitreous, and it's filled with a gel. That gel gives the eye shape and structure, and there's a little bit more involved to it. As the eye is developing, there's some blood vessels that are naturally there, so that before the retina has a chance to vascularize, that vasculature within the vitreous gives enough oxygen for the eye to grow. But when the eye is sort of done forming and it's done growing, the vitreous breaks down. And so I tell everybody it's a little bit like having a water balloon blown up inside the eye. And what'll happen is that if the water was frozen over time, it's going to liquefy, it's going to break down. And so the gel or the vitreous that's inside our eye naturally will change over time. It'll pull away from the optic nerve, it'll pull away from retinal vessels and an area we call the vitreous space. And then you have solid parts moving around in liquid, almost like, again, ice melting inside that balloon. We worry as retina specialists that sometimes when that vitreous separates or detaches, it can tear the retina. Sometimes we live with diabetes and blood vessels have grown in the back of the eyes. It can pull on those blood vessels, and that causes a new type of floater. So when we talk about floaters, the strands and membranes, the little sort of things that dance across the eye and a light colored sky or a light colored background, that's usually part of the gel. But if the retina bleeds or blood vessels bleed from the retina, you'll see a new showering of floaters, like a fine mist or a haze. And so I tell people, if you tear an artery, it's like bursting a snow globe in the eye. Thousands of little spots all at once that float through the vision. If you tear a vein, it's more like dropping food coloring in a glass of water that streams in the eye and then clouds. Now that's blood that's sort of entered the vitreous cavity, and that will settle. It'll sort of go away, and optically everything in the eye is upside down and backwards. So as blood settles in the eye, it really sort of retracts upward on our field of view. And so if you have a new sort of shadowing or showering of floaters, it's important to have your eyes looked at, because that could indicate a tear in the retina, or maybe blood vessels that have grown and bled from diabetes. But to answer your question, yes, floaters are sort of normal, and if we live long enough, they'll sort of clear up and go away. Very, very rarely I'll do surgery to remove floaters, but they have to be fairly severe before that happens.
Great. This isn't a question, but it's a question from me. Could you go through a basic anatomy 101? So you say things like lens and retina, and so kind of just go through a real basic anatomy lesson.
Yeah, that's a great sort of question. So I think of the eye simply like an old camera, not the digital ones, but the ones you have film in them. So the front of the eye is the first structure is called the cornea. And the cornea is a clear piece of tissue that's a barrier. It keeps everything out of the eye. And it's actually a living sort of tissue that is constantly pumping fluid through it that keeps it clear. People have heard about corneal transplants. It's one of the portions of the eye that we can actually replace. And we can replace the entire cornea or parts of the cornea. But think of the cornea as sort of like a lens on the outside of the eye, or more appropriately, more like a windshield of a car. So the cornea is sort of the very front structure. The cornea actually continues on into the white part of our eye that we call the sclera. And the sclera and the cornea are very, very similar. They're different in that the fibers in them either run straight or crisscross to give that sort of clear appearance or the white appearance, but the cornea and the sclera are what form the eye. Inside then, we have the front of the eye that we call the anterior chamber, and that has fluid in it. And the fluid is constantly nourishing the eye and nourishing the front. And it drains out an area we call the trabecular meshwork. Think of it like a drain, if you will. And then the front of the eye is sort of separated by a barrier. That barrier is the iris, which is the colored part of the eye. And behind the iris is a lens. And that lens is about the same size as, let's say, an M&M. and it basically helps focus light. When we talk about a cataract, what we're really talking about is a cloudy lens. It blocks the amount of light coming into the eye. So the iris is like an aperture. It opens and closes, letting light in the eye. The lens focuses that eye. And that whole system, the cornea, the iris, the lens, the fluid that's being put through the front of the eye, is all set up to basically simply focus light. That's it. If light focuses properly, we don't use glasses. If it focuses in front of the retina or behind the retina, then we're going to need some type of optical correction to be able to see better, whether or not it's glasses, contact lens, surgery on the cornea, which is what we call refractive surgery or LASIK surgery, surgery on the lens. Again, it can be removed. But the front focuses, the back of the eye is filled with that gel that we talked about, the vitreous, and then aligned with the tissue that we call the retina. The very, very center of the retina is an area we call the macula. And so just sort of like a camera, got to focus it, got to record that light. And then all that information that the retina records goes to the brain through a structure called the optic nerve. And the optic nerve is what gets damaged through glaucoma. So I mentioned glaucoma earlier, and glaucoma is a condition where the pressure rises. And over time, we can lose peripheral vision and eventually central vision if the pressure isn't detected and lowered. And so that's why it's so important to not only have your eyes dilated, but also get your pressure checked and make sure that the front of the eye and the back of the eye are all working well. I got back to that M&M portion. I like to describe cataracts like an M&M. So when we do cataract surgery, essentially everybody knows what an M&M is. And when we do surgery, we take the M off the M&M, we scoop out all the chocolate, and we're left with the candied shell. So we do an anterior capsulotomy, we remove all the lens nuclear material, and then we put a new implant in place. And that implant goes inside that basically candied shell, and that holds the implant in place. Now, sometimes that'll cloud over and people need a laser called a YAG capsulotomy to let light focus. But that all of the surgery we tend to mostly think of when we have surgery on our eyes is to get light to focus. And then, from my standpoint, the most important thing is the retina, and the health of the retina allows light to get recorded.
Super, thank you. And a reminder, if you have a question, make sure to put it in the Q&A. So that we can answer it. Okay, here's another question. I get a shot called Ilea in each eye every 2 months. Will I get my vision back to 100%? I lowered my A1C from 9.1 to 6.4. Good for you. But the answer is, can I get my vision back?
And that's definitely a good for you, right? We love hearing the A1Cs going down. We love hearing time in range is improving, right? We hope that, A1Cs dropped without having too many lows and all the good things that go along with that. To answer your question, Ilea is a medication. It's one of several medications that is a VEGF inhibitor, vascular endothelial growth factor inhibitor. And that's a medicine that's been around for, Ilea and other VEGF inhibitors have been around for close to 20 years. And what they do is they stop growth of blood vessels. They stop blood vessels from leaking, which causes further damage. And so the way I try to explain macular edema oftentimes to patients is, if I walked into a room and a sink was overflowing and there was carpet in the room and the carpet was getting wet, first thing I'm going to go do is turn off the sink and allow the carpet to dry up, right? And that's essentially what a VEGF inhibitor does. It stops permeability of blood vessels. It stops the leakage and swelling. And when that carpet dries up, it's going to be better, but it'll probably never be just like it was when we first bought it, right? It's had some damage. And so macular edema can cause damage to the photoreceptors. It can cause damage to certain cells within the retina. That doesn't always allow us to get back to that sort of 20/20 level of vision. Continued ongoing treatment is trying to prevent further damage. And so oftentimes when we start somebody on a VEGF inhibitor, Ilea is one of those, we'll have a loading dose. So we'll do a certain number of injections, let's say 5 injections, 1 injection every month, and then we'll go longer, and we can go up to, let's say, every 8 weeks, like the individual was talking about. And that is to help sort of stabilize, certain levels of retinopathy, and hopefully, reduce macular edema and reduce the sort of progression that occurs. What you're doing with your blood sugars is amazing and needs to be continued for a cardiovascular standpoint, from a renal standpoint. So that's preventing further damage, right? It doesn't sort of undo what's happening. And the most frustrating thing that I really feel that I encounter, unfortunately, on a daily basis is I'm seeing people when they're doing great, right? Their blood sugars have never been better. They've done so well in the last few months, and then they can't understand why things aren't getting better, right? And that's the really frustrating part, is that, we want to catch somebody before they've lost vision. We want to be able to stop retinopathy at its earlier stages. Once we have some damage, then it's sort of, we're just trying to minimize that as much as we can.
So that circles back to the same point of making sure that you get a good comprehensive eye exam every year, so that you start early. If you're getting if you can diagnose something early, you can intervene and make some changes. So we get right back to that same point. You just need to make an exam every year or so.
Yeah, and it is so
here's
hard.
another.
Go ahead.
Go ahead.
I was just going to say, it is so hard because we don't have all the time in the world, right? I mean, going in and seeing another eye doctor when you're already seeing a cardiologist or a nephrologist or a dietitian or, your primary care physician or a dermatologist or a podiatrist. I mean, the list goes on and on and on. There was a study that showed that once you have retinopathy and you're requiring treatment, chances are that you're having 25 doctor visits a year. Right? That's a month out of your life to go in and see somebody, right? And the eye doctors are a small part of that, but it just gets to the point of how diabetes affects every organ system, and how much effort it takes to sort of make sure those are all doing fine. And really the point tonight is, we want to catch somebody before they have to come in every 8 weeks and have an injection. We want to make sure that we can halt and stop that before they have loss of vision, because unfortunately, vision's part of it, but quality of life is another huge aspect, right? And we know as retinopathy worsens, quality of life diminishes.
Thank you.
Yeah.
Another question is, in recent years, I have found I'm sensitive to bright light. I was diagnosed with type 2 diabetes about 3 years ago. Is there a connection?
Yeah, that's a great question. And it's hard to know. So sensitivity to light, or what we call photophobia, is typically due to a scattering effect of light. And so light, when it penetrates the cornea, it can be sort of scattered, almost like on a bright sunny day, if you have frost in the windshield of your car, how you get that sort of, glare sensitivity, that can be part of it. So sometimes the cornea can have issues, like dryness could be part of it. So moving deeper into the eye, sometimes our iris doesn't always respond the way it should, and it lets more light in than it normally would. But more commonly with diabetes, we tend to develop cataracts earlier in life. And so we talked about a cataract blocking light. Cataracts can also scatter light, and so they can cause glare or halo effects that we get, and that causes us to be more sensitive. Moving deeper into the eye with the retina, oftentimes if we have trouble with our central vision, our macula, we sort of eccentrically fixate. We look a bit to the right or left. We use more of our peripheral vision. And the way the retina is set up is there are these cells called photoreceptors, cones to help us see clearly, essentially, color and clarity and contrast, that are more centrally located, or rods that help us move around in lower light situations or see movement. They tend to be very, very sensitive. And so some of that sensitivity could be where we're looking at with more of the peripheral retina, and that's a little bit more sensitive as well. But again, sensitivity to light is usually the early sort of signs of maybe a cataract starting to form. Or occasionally, sometimes even after cataract surgery, we get even too much light coming into the eye, and people tend to be more sensitive after cataract surgery.
So a question, should people be wearing sunglasses? I mean, does that help them prevent getting cataracts? How does that play a role?
Yeah, so there's a lot of sort of thought about ways that we can sort of prevent the aging process, right? And so I hate to sort of be the bearer of bad news, but if we live long enough, we'll probably develop cataracts, and we'll probably develop other eye problems. But certainly protecting our eyes at an early age is important. And so if I had sort of the time in which I wish I had been wearing sort of sunglasses myself, it was probably when I was, playing on the, jungle gym in, third grade, as opposed to, driving into work and putting on my sunglasses. As we age, our lens naturally starts to cloud and block out some of those wavelengths of light. And so, if we're going to do anything for our eyes and eye health, always good to start early. And so wearing sunglasses is helpful. But sunglasses can also block out some light. And sometimes we have lower vision and we need, enough light to be able to see. Sunglasses can be harmful for us in that we just don't see as well. And so I always sort of tell patients to try on, either a yellow tint or a rose colored tint, because that's going to block out some of the light, but pull up some of the contrast and allow us to see better.
Perfect. So questions coming in about prediabetes. Should the person with prediabetes also have an annual comprehensive exam?
Absolutely. Not necessarily because of diabetes, but again, getting back to the fact that, eye health is very, very important. And, the reality is diabetes related retinopathy or diabetic retinopathy takes years to develop, right? And if we have pre-diabetes, we're not going to really develop microaneurysms or neovascularization or macular edema, all terms for basically levels of retinopathy that can affect our vision right away. It takes years for that to really develop. But if we have pre-diabetes, we want to try to do everything we can to sort of, delay that onset if we can. And, checking lipid levels and blood pressure and is no different than us checking eye pressure or checking for other changes that can affect our vision. And so, there's a lot of reasons to go in and see somebody. A diagnosis is one of them, but from my standpoint, it's the overall eye health that you're really hoping to be preserving.
So I think you talked about this earlier, but to clarify, the question is the camera exam a reliable substitute, or should a person with diabetes prefer or insist on a dilated eye exam annual? And I think you even mentioned the comprehensive eye exam, not just dilated.
Correct. Yeah. So I believe that, we are going to get so much further along someday with cameras. I think that we're going to be able to take photographs of the retina, and we're going to have, a artificial intelligent program that's going to read those images, and they're going to be able to sort of stratify individuals at risk. And so my hope is, Carla, you're going to have a non-Brigitte camera in your office one day. You're going to be able to, as you're educating somebody, take a picture of their retina, or maybe your endocrinologist or primary care physician will have a camera that'll take a photograph, and that will help stage levels of retinopathy and know how abruptly we need to get somebody in to be referred. And so if we screen enough people and pick up enough people, we'll be able to prevent visual loss. So cameras are going to be a vital role. If you're in front of your eye care professional and you are having your eyes looked at, my bias always is to have a dilated exam. It is one of those things where we're able to sort of pick up a lot of changes that we can't always see with a camera. Cameras are great, but they don't quite see the entire scope of the retina. And one of the things that we realize is that when we first started staging levels of retinopathy, we had to do sort of 7 fields. We have to take pictures in 7 different locations and sort of montage them or tape them together to get a full field of the retina. And we were still missing areas. And so on a dilated exam, we have a much wider field of view. But cameras have gotten better. We now have a wide field image that we can see that actually outpaces what we were able to do, decades ago with cameras. But eyelids still get in the way, and I can still pull down a eyelid, and I can still check the peripheral retina for, any tears or any changes that we don't always sort of pick up with photographs. But again, I think that, if you're seeing a good eye care professional, they'll be able to direct you into what you really need.
Well, and I think distance is a big thing. I mean, we all know about the virtual issues,
Absolutely.
but, for people living in Podunk, Alaska, for example, or Montana or wherever, it's a nice tool to use
Absolutely.
that people may not be able to get to a specialist.
Yep. And I think what'll happen with those tools is that they're going to screen individuals. So when we talk about, needing an exam every 1 to 2 years, that's probably important to screen for glaucoma and for cataracts and to make sure that, there's no need for updating glasses. But as far as retinopathy, if there's no levels of retinopathy on those images, those, algorithms will probably say, okay, you need to come back in another 2 years to have another picture, right? Doesn't mean that you can't develop glaucoma or cataracts or have other conditions that can affect your vision, like macular degeneration or other diseases. But it is one of those things where you're absolutely right. There's a time and a place for most things. I just think that realizing that retinopathy is asymptomatic, that we don't know we have it, and if you can detect it with a photograph, great, right? And if it's that severe that you need to get in to be seen, even better. Then hopefully we're going to get that individual in and get them cared for.
Right. Another question, I often have trouble focusing my right eye. My optometrist said that there is no evidence of any damage, but this bugs the heck out of me. Is it possible to affect vision by sleeping on your side and the pillow putting enough pressure on your eye to affect you all day?
So the answer is you can certainly do things at night that can irritate the cornea. And if the cornea is irritated in the morning, it's going to really be cloudy. Now, oftentimes that irritation tends to improve as the day wears on. There are conditions where the endothelial cells or cells in the cornea don't function quite as well. And so the cornea can sometimes swell at night and then improve throughout the day. The hardest part is sometimes what a patient will see and what we see, there's sometimes just a disconnect, right? If we're seeing sort of a normal exam, but we don't have a reason why, it's probably good for that person to get in and have what we call a fluorescein angiogram. A fluorescein angiogram is a vegetable-based dye that we inject through the veins, and we're able to see the circulation to the retina, in particular circulation to the macula, because like we talked about with retinopathy early on, you can have blood vessels break down and leak fluid and cause swelling, but sometimes those vessels can shut down. And if you have some ischemia or poor circulation to the macula, it may be that there's some damage there that even with the best pair of glasses, we can't quite get to focus, right? And so it's a little hard to know exactly why that's the case, but usually when there's sort of unilateral visual changes and we don't have a great visual reason why structurally there might be, no cataract or the lens looks good, we're not seeing much in the way of astigmatism or other changes, then it's probably good to see what the circulation looks like.
Great. Are there vitamin and mineral supplements that are helpful for eye health? Or
Absolutely.
good diet?
Yeah, exactly. So you just sort of, stole my thunder. I tell people that I would rather have them spend their money on food than I would vitamins, right? And so if we eat green leafy vegetables, fish over animal fat, great, right? Now, if we're a tea and toast type person and we're looking for ways to improve our eye health when we live with diabetes, it's basically cutting carbs, or counting carbs and dosing appropriately for them. The eye vitamins that you see in the stores and the antioxidants, they're good for moderate to advanced age-related macular degeneration. Initially, when vitamins were investigated, the hope was that we could slow down cataract formation or that we could affect other conditions. And what we found was that eye vitamins were only good for moderate to advanced age-related macular degeneration. They didn't really do much for the formation of a cataract, and they really didn't help retinopathy related to diabetes. And so, the vitamins that we're talking about are lutein, zeaxanthin, vitamin C, E, zinc. But if you want to do anything for your eyes, again, make sure you have a good exam, make sure that you're eating well, and really, in addition, control blood pressure and don't smoke. I mean, it should, not have to be said in 2021 that we shouldn't be smoking, but, I keep telling my brother who still smokes that he needs to stop. And, it's hard to stop things that we've done for 40 years.
what about blood lipids? You mentioned hypertension and smoking.
Yeah,
And
so lipid level or dyslipidemia that occurs with diabetes is so critically important. There was a study several years ago look at it, at sort of a cholesterol lowering medication to see if it can help stabilize or reverse levels of retinopathy, and there is some improvement there. It all goes hand in hand, and so if you really sort of think about it, I try to explain. Um, a blood vessel like a steel pipe. And when I tell patients, or let's say a gardening hose, that's probably a better example. Everybody knows what a soaker hose in gardening is. And when we have diabetes, elevation in blood sugars basically eats away at the lining of those blood vessels. It basically creates loss of cells that we call parasites. And it's like poking a hole in a little garden hose. And so that area is going to leak fluid. Now, if your blood pressure is higher, you'll have more fluid leak out of those little holes, just like you turning up the faucet on the garden hose, you'll have more leakage or edema. Lipid levels clogs up the vessels. And so when we talk about hyperlipidemia causing damage, there's two ways that happens. It shuts down circulation. It causes ischemia, just like, if you close off blood flow in the neck and have a stroke, or the heart and have a heart attack, you can shut down retinal vessels from cholesterol levels. But more importantly, what happens is that sort of fine little lipid leaks out into the layers of the retina, and then it accumulates there. And that sort of hard exudates within the retina further damages it. And even though we can, with medications like Ilea or other anti-VEGF agents, reduce that swelling, oftentimes that hard exudate is left behind, and it doesn't sort of get resorbed for really years sometimes, and that causes permanent damage. So when we talk about ways to help our eye health, aside from stopping smoking, controlling blood pressure, cholesterol is right up at the top of that list.
Great. What causes a star on the eye filled with white substance? Is this a sign of diabetes eye, especially if it keeps coming back?
So that's a question that I don't know quite how to answer, because I'm not sure what they mean by a star, but I will tell you we can sometimes have ocular migraines. An ocular migraine will create what we call a scintillating scotoma. And oftentimes we get these sort of jagged little lines that sort of gradually enlarge in our visual field and then retract and go away. And that's related to vasospasm within the retina itself. Doesn't have to be associated with a headache. It tends to be transient. It tends to, sometimes be brought on by stress and dehydration, sometimes fatigue or caffeine use, hormonal changes, all the type of things we tend to think of with migraines. But typically the scintillating scotoma can sometimes give that star appearance, right? So that might be part of it. There is also another condition that we call Charles-Bonnet syndrome, which is where the brain sort of is filling in blank spots in our visual world. We tend to see that much more commonly in severe visual loss, let's say from macular degeneration, when patients will see abstract images or formed images. It's sort of the way our brain is trying to make up for what the eye is missing. But if we're seeing those sort of stars, I think that's probably related more to an ocular migraine, if I had to guess.
Thank you. And how are glaucoma and diabetes related? What is the relationship?
Yeah, so that's a great question. So typical glaucoma is going to affect the optic nerve, and the optic nerve is that structure that takes information and sends it to the brain. And that's brought on oftentimes by elevation in intraocular pressure. And so at the advanced stages of retinopathy from diabetes, new blood vessels can grow, and we call that the proliferative form. Well, those blood vessels typically tend to grow off the optic nerve, along blood vessels in the back of the eye. They can break open and bleed and cause scarring. But they could also grow up into the front of the eye. And we talked about the front of the eye having the iris and the trabecular meshwork, which is a drainage system of the eye. Those vessels tend to grow into those structures, and they can basically clog the drain, if you will. So fluid's being made inside the eye and it has no way to get out. And that raises the pressure. And we call that anterior segment neovascularization. And so that's new vessels growing related to, unfortunately, retinal ischemia from diabetes.
So in addition to that question, this individual asked, what is a healthy blood pressure and what are healthy lipids? I mean, I think we talk about that. And so there are different numbers for different people, but what is kind of a general consensus?
So I will tell you that the eye is an end organ, right? And when we see hypertensive retinopathy causing trouble, like a vein occlusion or either branch or central retinal vein occlusion, or we see hypertensive retinopathy, it's of that end organ damage. So it's basically a blood pressure of 200 over 100, and that's or higher, and that's where we really start seeing occlusive disease, hemorrhages, and severe damage. Ideally, we're going to want, obviously, blood pressure much lower than that, so 160 over 90, or, if we can get it even lower in a safer range, I would prefer my patients to have blood pressures lower than 140 over 80. But, it's a lot of times goes with sort of what their renal health is and how they're functioning from that standpoint. As far as dyslipidemia and cholesterol levels, it's one of those things where sometimes I'll put patients on fenofibrate or something if I'm seeing lipid deposits within the layers of the retina, and talk to their primary care physician or their endocrinologist, whoever's controlling their lipid levels. But I tend to sort of, concentrate more on the hemorrhages and the swelling than I do lipid levels for the most part.
So good to go back to your endocrinologist or your primary care and have that discussion to make sure you're within target range.
Yeah, target range is important, and I think that's an important thing. When you go in to see a physician, you're going to have hundreds of different questions going around your mind and trying to figure out concerns. Write them down, right? I mean, I always love when patients come in with a list of questions, right? And they think that they're bothering me, but it's an organized thought process, right? Because I can be talking about something that you already know about or that you're not concerned with. And really my time with a patient is supposed to be meant trying to give them information they need, right? And, I think that, there's a lot of good resources we can direct patients to, but you're going to have your own set of questions and concerns, right? That's why we're doing this tonight, to try to answer some of those. But write down questions. We love that.
Yeah, that's a really good point. What about eye pain?
Yeah, so pain is interesting. There's no pain fibers in the retina, so I can't really blame retinopathy on pain. There's a lot of pain fibers in the surface of the eye, right? And it's why we blink so often. It's why the eyes can get irritated if they get dry or have something in them. So pain and sharp shooting pains we get that we blink and arrest the eyes, and that pain goes away, is related to the surface of the eye. A deep sort of dull ache that, let's say, keeps you up at night or even sometimes gets you sick to your stomach, right? We can have nausea and vomiting with pain. Could be a severe elevation in pressure. So advanced glaucoma or acute angle glaucoma, where the pressure rises abruptly, can cause extreme pain. Very, very, very important for everybody that's maybe listening that is getting injections. There's risk with these injections. So I've talked about all the good things. I've talked about the fact that we're able to stop and reverse levels of retinopathy. We're able to help stabilize and improve vision sometimes. But those injections run the risk for infection. And so if you have pain or any visual loss a day or two after, or really if you're having concerns afterwards, you need to contact somebody and be seen, because we worry about what we call endophthalmitis. Endophthalmitis is an infection that can develop inside the eye after an injection. Very, very rare, but it's one of those things where if you get an injection and you're having pain, you need to sort of make sure that you get in to be seen for that.
So here is a very personal testimony. Someone writes in that they've dropped 100 pounds, got their diabetes under control, and their vision improved. This was 3 years ago. The weight is still down. Congratulations, by the way. And the vision is now getting blurry again.
Yeah. And it may be unrelated to retinopathy, may be unrelated to diabetes. And again, with diet, exercise, appropriate medications, as we're able to stabilize levels of retinopathy, that's great. That's going to prevent further damage from edema or ischemia. But there could be other things going on, right? We could have a cataract forming, or we could have, again, some visual loss from glaucoma or other conditions. And so it's important to make sure that obviously you keep doing what you can from a weight reduction and from a, glucose control. But again, that's where that sort of comprehensive exam sort of makes sense to sort of pinpoint maybe why the vision's decreasing and what can be done to help it.
Thank you. My doctor recently put me on isosorbide, there you go, for heart issues. Will this affect the blood vessels in my eye and increase risks?
So again, anything you're going to do for the most part that improves cardiovascular health is going to improve ocular health, right? So the eye is just an extension of the heart, as painfully as it is for me to say that, right? The vessels in the eye start at the heart, right? And they, sort of blood leaves through the heart, up through the aorta into the carotid arteries. And one of those branches off the, carotid artery is the ophthalmic artery as it comes up into the head. And that ophthalmic artery that travels through the optic nerve branches into the layers of the retina. And so if you're able to control blood flow through the retina, that's going to really help retinopathy. Same thing goes with, let's say somebody's wearing a CPAP machine, right? Again, we know that sleep apnea is something that oftentimes gets undiagnosed. And one of the things I oftentimes see is that when sleep apnea is appropriately managed and patients are wearing their devices, their retinopathy improves. We see improvement in the vasculature within the layers of the retina. Same thing with, again, controlling blood pressure, lipid levels. It's all connected.
Can you discuss eye strain related to all of our computer usage now?
Yeah, it's a long night, right? And we've all been working on computers, presumably, and our eyes are getting tired and, it's hard to focus. So when we are really working, studying and looking at something, driving, watching television, staring at these screens, we're blinking less. And as we blink less, the surface of the eye can dry out. And so the first thing I always sort of tell patients is, if you are having trouble, close your eyes, right? And there's this sort of rule of 20-20-20, and I always sort of forget it, but it's, you close and rest your eyes for 20 minutes, right? For 20 seconds, sorry, it'd be great to close them for 20 minutes, but for 20 seconds, close your eyes, right? Open them up, look 20 feet away. And what you're doing when you're looking away is you're relaxing the ciliary body. So one of the things I didn't mention inside the structures of the eye is there's this muscle, we call it the ciliary body. And what it'll do is it'll contract or relax to help focus the lens. And if you're staring and that muscle is constantly basically sort of tightening, it needs time to relax. And so when you look away, you're changing that focal plane, relaxing hopefully that muscle and allowing your eyes to sort of refocus. So close your eyes for 20 seconds, look 20 feet away, and then try to do that every 20 minutes or so, right? So that 20-20-20 rule is something that the American Academy of Optometry came up with. And I think I love it. It's great. It makes a lot of sense. It just reminds us that when we're really staring and concentrating, our eyes are getting drier. We're straining them, trying to sort of concentrate on what we're seeing and looking at. And we need time to relax, and we need time to sort of, get up and move around. It's also good not to sit for more than 20 minutes, right? We want to get up and exercise just a little bit.
We need to insert some exercise sessions into our session.
That's right.
So here's an interesting genetic question. My dad has had diabetes for over 30 years. My sister's had both cataracts replaced, but she doesn't have diabetes. I've been diagnosed with type 2 diabetes, had gestational diabetes 25 years ago. What are my risks genetically of getting cataracts?
Well, I would say, again, if we live long enough, we're gonna develop cataracts. And so, I'm probably fairly pessimistic. I sort of tell everybody, if we get to live long enough, we're going to have some age-related problems. And a cataract is a cloudy lens. Now, I've seen individuals well into their hundreds that have cataracts, and they've not had cataract surgery yet. And I've seen people come in their 30s or 40s that need cataracts, and some of it is genetic. Some of it's related to diabetes and how diabetes affects the lens. We oftentimes get different types of cataracts when we have diabetes. But a lot of it depends on the individual, right? If somebody is a truck driver or a school bus driver that are driving at night, right, that needs good binocular vision, and they need to have a certain level of vision to do their job, they're going to become more symptomatic than somebody who, sure, it's a little cloudy at night, but I don't need to go in and, out to do what I'm doing. I can, have somebody else drive for me. It's a lot of, how active we are and how much we're asking our eyes as to when we really become symptomatic with cataracts. Just because, a doctor tells you have a cataract, you really have to ask yourself, is it affecting my reading? Is it affecting my driving? Can I work? Can I function? Am I happy with my level of vision, right? Because, those are questions you have to answer for yourself before we call it visually significant, right? I sort of joke, I'm losing my hair if you can't tell. So, some people say I'm bald. Other people say, nah, you have a lot of hair, right? And, but it's all subjective, right? A cataract, when we look at it, it's not like it's black or white. It's, how much is it impacting your quality of vision?
So this kind of follows that up, because someone said, would you recommend cataract surgery for anyone with cataract? I think you kind of answered that, but.
Yeah. Yeah. So again, it depends on, there's probably two directions I want to go with this question. So I recommend cataract surgery when someone's quality of life is being limited, right? Cataract surgery is probably one of the safest surgeries in the United States. It's certainly the most common, and it's usually has very low complication rates. Now, here's the catch. If we have diabetes and we have diabetic retinopathy, we want to have that under control before we undergo cataract surgery. And so if we have macular edema or swelling within the layers of the retina due to diabetes, you want to control that before you have cataract surgery. When we do surgery on an eye, it's going to promote inflammation, and that inflammation can create more problems and damage. And so oftentimes, what will happen if someone has retinopathy, they'll get that under control first. And then if there's a cataract, take the cataract off and then continue to monitor and follow. And so it's one of those things where cataract surgery can be done easily in someone who lives with diabetes. We want to make sure the retinopathy is stable before proceeding with that.
Thank you. How does aldose reductase contribute to diabetic retinopathy?
There are many different pathways in which retinopathy can occur, and if we sort of look at sort of what's happening, there's like we've talked about ischemia, there's leakage and edema that can affect retinopathy, but right now, as we are in 2021, the only hammer in our toolbox are VEGF inhibitors, right? And when we look at the future, we're going to have other pathways to be able to help with retinopathy. Oftentimes we'll use corticosteroids for inflammatory processes. We'll look at, the Tie2 pathway or aldose reductase, inhibitors that might help with levels of retinopathy. But, the reality is, it's sort of multifactorial. So there's not just one sort of solution, aside from, quite honestly, glycemic control and limiting glycemic variability, right? I think that's probably if I had any one device aside from insulin for my daughter, it's going to be not her insulin pump, but it's her, CGM monitor, right? And trying to limit, her variability, I think, really goes a long way to really preventing retinopathy, much more so than we realize at this point.
Thanks. That's a big topic. We'll get to that at some point with these sessions too, is time and range, which is great.
Yeah.
This wraps up our last question for the session. A few items before we close today. 1, 2, 3 important tips. Work towards achieving glucose values within target. Maintain healthy blood pressure and lipids, and make an appointment yearly to see, if recommended by your eye care provider, for a comprehensive dilated eye exam. And Dr. Cooper, do you have another tip to add to that?
Don't panic, right? I think that it's one of those things where we all fear losing vision. It's probably one of the biggest fears that we have. And, my job and eye care professionals' jobs are to ensure that doesn't happen. And with appropriate treatment and care, retinopathy should not advance to the advanced stages that cause visual loss. So that would be the biggest thing I'd say. Don't panic.
Great. To help you feel confident about your ability to prevent and treat diabetes-related eye diseases, we encourage you and your loved ones to talk to your healthcare provider about your risk. Schedule an annual dilated eye exam, whether you have symptoms or not. That's key, remember. Go to eyehealth.diabetes.org for more resources. Remember to celebrate Healthy Vision Month. That's all May long, and we're going to have quite a few activities for that. Make sure you have made an appointment to see your eye care specialist for checking for any possible problems you may have. Thriving with diabetes takes a village. We're here to support you. Special thanks to Dr. Cooper. Always enjoy having you. I am Carla Cox, and on behalf of the ADA team, we want to thank you for joining us today. And we look forward to connecting with you on our next Ask the Experts Focus on Diabetes event, July 27, Preventing Sight Loss, What's in Your Toolbox. In addition, check out our website, diabetes.org/experts for other events throughout the year. We are sorry we were unable to get to all of your questions during this live Q&A event. If you have questions about this event, you are welcome to contact us at askada@diabetes.org or by calling 1-800-DIABETES. Numerically, that is 1-800-342-2383. We'd love to get your feedback on this event. Remember to look for our short survey in your email box. Your feedback is very important to us and will help us plan for the future meetings. Thank you very much and stay well.